As you can see, we're off to a great start this morning. It is my honor and pleasure to be able to introduce to you Cammie Wolf-Rice. Cammie, go ahead. Yes, ma'am. Yeah, absolutely. Hit it. Her reputation precedes her. We're going to do that, and then we'll do that again, okay? Cammie Wolf-Rice is a renowned philanthropist, activist, and speaker dedicated to ending the opioid epidemic. After the tragic loss of her son, Christopher, in 2016, Rice turned her pain into purpose. That's a key foundation, pain into purpose, by founding the CWC Alliance, Christopher Wolf Crusade, in his honor. The CWC Alliance has since pioneered a new role in healthcare, the Life Care Specialist. Successfully implemented at Grady Memorial Hospital since 2019, the LCS program expanded into rural hospitals last year and continues to grow. Rice is the author of The Flight, My Opioid Journey, a memoir detailing her personal and transformative journey through the opioid crisis, a testament to her resilience and commitment to advocacy. The book includes QR codes and access to an ever-updating resource library. In addition to her work with the CWC Alliance, Rice is actively involved in various philanthropic endeavors. I'm going to get through it. Philanthropic. There you go. I had to fix it. The English major in me wouldn't let me go on. Since 2022, she has served as the chair of the board of directors for Usher's New Look Foundation, a nonprofit dedicated to transforming the lives of under-resourced youth around the world. Rice is a board member of the Cambodian Children's Fund and Partnership to End Addiction. She is also a member of the Georgia Attorney General Opioid Task Force. Rice is a sought-after speaker, sharing her insights with experiences at prestigious events and institutions nationwide. Her appearances on various television and podcast platforms, including NPR's TED Radio Hour and Radio Health Journal, further amplified her message and advocacy. Rice's professional background includes significant roles in finance and technology, including her tenure as Senior Vice President of Bank of America and Senior Director of Hyperion Solutions. Her entrepreneurial spirit is evident from her founding and leadership of Digital Connectivity, Inc., the systems integration company. And I'm just proud to call her my friend. Please welcome her today.
Wow. Did my husband hear all that? Did you hear all that, honey? That was awesome. That was awesome. Oh, good morning. How many of you have had a health crisis and been in the hospital? Raise your hand. Multiple times, maybe, even? Okay. How many of you have been a caretaker for somebody in the hospital? Everybody. Okay. Right. Okay. Well, this is Christopher. This is my baby. And I like to start, every time I talk, I start with my son, because you need to know about who he was. First of all, huge hugger. If you met him, he's going to get in your space and he's going to hug you. Whether you're a hugger or not, he's going to hug you and act like you're the only one in the room. He was really, really book smart and disciplined, an AP student, and he wanted to be a Navy SEAL. That was his dream. And today is his heavenly birthday. So a little emotional. And it's okay, because today is it's not about perfection. It's about connection. And when Dean Sumner said, hey, let's do a conference together, and my heart's beating out of my chest. Oh, really? Oh my gosh, we're going to do a conference? Yeah, we need to do it in September. I said, oh, September. And my brain immediately went, oh, that's a hard month for me. That's Christopher's birthday. That's recovery month. And when I told her it was September 18th, well, that's the day we're going to do it. And what a difference it's made in my week, in my month, looking forward to this, standing here, because I will tell you, he's here. He is shining down, and he is so proud and so excited to see all the work that's been done in his name, in his honor. And Christopher had a health crisis, and it was ulcerative colitis, and he had to have a major surgery. And we were in the hospital for many, many, many days. And it was right when Oxycontin was released as the wonder drug. And I didn't know what questions to ask. All I knew is that my son was in pain. I was told to give him these pills every 4 hours. And as a mother, that was my duty to do that. And we went home with 90 Oxycontins, followed by 90 more. And those prescriptions, in actuality, the first prescription, because he was on morphine in the hospital, taking the Oxycontin, his brain was already hijacked. And I didn't know it, and he didn't know it. Our family knew nothing about substance misuse. No idea. He went on to go to college. He went on to get a degree. But then one night at the kitchen table, he said, I've got a problem. I need help. We got him into treatment. And I always say my PhD is an MOM because I've gone through 14 different treatment centers. No, not 14 years. I'm sorry, 14 years and multiple treatment centers. And we fought it together hard, and he fought it hard. And every time he had a relapse, he thought he was failing me. He thought he was failing John and his brothers. What's wrong with me? Why can't I get better? But it was part of the disease. I didn't know it either. So I was confused. Why is this not working? Because guess what? You don't go into treatment and you write a check and 30 days later you come out and everything's great. That is false. That is not true. It does not work. But it does take love and connection, and you never give up on your loved one. That I know. But in 2016, February 26th, he passed away, but he's at peace. But it took me 2 years to say that my son overdosed. Why is that? Does anybody know? Stigma. I know what everybody was going to think of my son. I didn't even say it to my family. You are not going to think my son is not having a disrespectful death. Because I know what people talk about. I know how they talk about addicts. I know what's in their head when they think, oh, overdose. Oh, is he in a junkie in an alley and he just didn't know? No, that's not my boy. He didn't ask for this disease. He went into the hospital with one disease and he came out with another that killed him. And he should be here. It didn't have to happen. So it took me 2 years. I was journaling because that's what my therapist told me to do. I was writing it out and I said, there's a missing piece in the healthcare team. I had no idea what was going on. I had no idea what to do as his caretaker. So our mission at CWC is prevention. We have to stop it before it starts. That's our long thing. I'm not going to read that, but it's good. I can go over stats, but what I'll tell you is 80% of heroin users started with a prescription. And when Christopher couldn't get that prescription filled any longer, there was no conversation. It was, oh, I'm sorry, you can't fill it. Bye. What's he going to do? Does anybody know what he did? He went to the street. Heroin. It absolutely was mortifying when I found that out. I didn't even know what to think. But his brain and what he explained to me is, Mom, just like you need air to breathe, my brain is constantly telling me I've got to have the drug. I've got to have it. And so he went to the street and got on heroin. Less than 3% of healthcare spending goes to prevention. And that's why I knew that that needed to be CWC's swim lane, is prevention. Why not pick one of the hardest things in the world to do? Let's develop a new position in hospitals. So we wrote up a business plan with my genius husband, my better half, John Rice over there. And we met with over 150 medical professionals. This is before I met Dean Sumner. Anybody that would talk to me, and I would give them the plan, and I would say, put holes in this. Tell me what's wrong with the plan. And everybody said, oh, no, this is really needed in hospitals, but it's all about the money. I said, oh, okay. We'll figure that out. So let me tell you about this role. In our society, our culture has been trained to think ill, pill. That's what we think. Even when we have a headache, immediately, headache, pill. We have to change a culture. And if you look at our society, we have coaches for everything. Can you imagine UGA playing without football? Defensive coach, head coach, offensive coach. There's lactation coaches, workout coaches, executive coaches. But when you're in a health crisis, there's no coach. Nurses are extremely busy. They don't have time to be that coach. So the life care specialist is a new position at patient bedside. Their job is to help you manage your pain. If you have to be on an opioid, and there is a time and a place, you need to understand the dangers and how quickly and how vitally important it is that you taper off those opioids quickly. The life care specialist has an arsenal toolkit full of things for pain distraction that are non-addictive. How many of you, when you have a health crisis, raise your hand if you had anxiety, stress, PTSD, because you've been in the hospital maybe the second or third time? So you have all three of those things. So there's the mental side of being in the hospital. All of the life care specialists are trained with the Trauma Resource Institute to provide coping skills at bedside to help you with anxiety, stress, depression, and PTSD. Because there's the physical side of getting better and there's the mental side of getting better. So those are the three pillars: opioid safety, also teaching about naloxone, pain management techniques, and mental wellness. This is our healing wheel. We try many different things because everybody deals with pain differently and everybody has different tolerance for pain. Let me tell you one of the most important things on this healing wheel: a listening ear. If you have someone at patient bedside that's validating your pain, that's just listening to you, that immediately can help with the pain because you have someone just sitting by you talking to you. But guess what happens? When you spend time with that patient and you're listening, you uncover all these other comorbidities. And then you find out, oh my gosh, we have food insecurity. There's housing insecurity, domestic violence, sex trafficking. The list goes on and on and on. So that patient could have fallen through the gap at that hospital stay. But because they've got that health coach that's spending time at the patient bedside, we're able to connect with the social worker, connect with the outside services, and to get them the extra needs that they have. It's powerful. Let's talk about Mercer. I said this last night at a dinner that we had. Dean Sumner is my shero. I love this woman. She has been my champion from the minute we met. And she said, I want to help you with the certification, with the training. And we had some good training. But Mercer School of Medicine took it to a whole nother level. The faculty here all got engaged. And it's 13 modules. And it's an online curriculum. So the LCS goes through those 13 modules. They have a quiz after each module. Then they go through the practicum. So we started our program at Grady. Grady took a risk on me. They had no idea what a life care specialist was. And I'm going to bring Mara up here in just a moment, another shero of mine, because let me tell you, it's all about partnering, but our training is robust. And they're all here today, and we continue to give them that education, and we're continuing to look at innovative ways to manage pain. So thank you, Dean Sumner, Glenda Grant, the entire Mercer team for hosting our online curriculum here at Mercer, because again, it took our training to a whole nother level. We also wouldn't be where we are if we didn't partner. That's the name of the game. If you try to do things in a silo, it's not going to work. And we've got some amazing partners. All the hospitals that you see listed here, Vicki Lewis is here, the CEO of Coffee Regional Hospital. That is a statement that a CEO of a hospital, you know how busy that woman is? And she's sitting here today. That's the power of partnership. And then we are now announcing we just received opioid abatement money to launch a youth program, a youth prevention network in the state of Georgia. And we're going to have Felicia talk to you a little bit later about our youth program. Harvard Business School, they've done a case study on the life care specialist. Because we had 300% growth in 1 year, they decided to follow us on our entire journey. They will be doing a case study continuously throughout the life care specialist journey. That's a big deal. I was excited about that. I got to go on Harvard campus and talk to the students. It was amazing. We've also been featured on WebMD and the Atlanta Constitutional Journey. I'm going to try to play this video because this is going to be airing this Sunday.
Opioids, fentanyl, Georgia in crisis. Families forever changed by unimaginable losses.
I've lost my son to the opioid epidemic and my only sibling to the fentanyl crisis.
Survivors' stories of hope.
There is light at the end of the tunnel.
And how they're turning their pain into purpose.
Join us for a powerful discussion about the impact of the opioid crisis on Georgia.
And the real solutions for people who need help.
Georgia's opioid crisis. Sunday at 7 on Channel 2.
Yes, I'm doing a little promo. Okay. It's Sunday night. Have a watch party. I'm so excited. I'm just so excited about it. And it's all this week, right? Do you see how good God is taking care of me this week? All right. Now, talking about Sheroes, Dr. Mara Schenker as a chief orthopedic. I'm going to let her tell you all of her titles and her letters because it's like reading the alphabet after somebody's name. But the most important to me is that she is CWC's chief medical officer. And if you would join me up here, Mara, please. So I'll start by saying I heard Dr. Mara speak at a Grady internal meeting that I sneaked in on. Don't tell anybody, Pooja. I sneaked in on, and after she talked and what all the things that she said, I always say I stalked her. I kind of did. But then she became the chief medical officer for CWC and also a best friend. And when I keep talking about Sheroes, it's the power of when women support women. I love all you guys out there, but I'm just saying, I've got a powerful group of women that support CWC. Mara, would you please tell us what you do at Grady?
Sure. So Mara Schenker, nice to meet you. I've been at Grady now for 10 years in September, just at my 10-year anniversary. I'm the chief of orthopedics, although I'm transitioning out of that role in the beginning of this year, and I'm also the associate chief medical information officer. So I'm going to be spending a lot of my time both doing surgery and helping run our IT for the hospital.
So, ladies and gentlemen, she's really smart. That's all I got to say. So, as a surgeon, you've spoken openly about the realization, like many providers, that you were relying on opioids and you didn't even think you were part of the issue or the problem of the opioid epidemic. Can you talk a little bit about that?
Yeah, so I love to read, and one of the books that I had read right before we met was Dreamland. And, you know, when I trained, we were sending people home after a total hip or total knee replacement. I mean, it's not all that long ago, with 120 Percocet. Like, I remember writing several prescriptions every single day for 120 Percocets, sending people home. And So I started reading Dreamland because, you know, the lay press was saying all about how we were overprescribing. And I went to my PA, who I've worked with for 10 years, and I said to her one day after I finished the book, I was like, so where, you know, I clearly prescribed the least of everybody. And she was like, no, you don't. You prescribe the most. You're the most willing to refill the pain medications. And, you know, at the time I was like, well, why? And it sort of made sense to me because I wanted to treat people's pain, and so I was, you know, sympathetic and empathetic to the pain that they were experiencing, because, you know, I do trauma at the busiest trauma center in the United States, and these, you know, patients are coming in with horrible injuries that change their entire lives. They, you know, a lot of them have underlying substance use disorders, and a lot of them have, you know, very complex social situations, and so I was wanting to treat their pain, and so it was coming from a good place. And I also also didn't have anything else to sort of substitute it with. So it was like either you get a pill or you get nothing. And that was the two things that were in my tool chest at that point. And so I started talking more about it and reading more about it. And that's how I gave the talk that Cammie snuck into, which she didn't mention was it was like a monsoon outside too. So both of us almost skipped the event because it was raining so hard. But that's where we connected.
Yes. Tell us about your experience when you went to med school, on how much training did you have on addiction, substance misuse, and pain management?
So I'm an orthopedic surgeon. I think we still are the number 3 highest prescribers of opioids. I got 0 days of pain management education at any point in my 16 years of training. So I did 4 years of college, 5 years of medical school, 6 years of residency, and 1 year of fellowship. And I learned how to treat a fracture with the best of them. But I had, we were sending people home with a lot of pain medication. So the short answer is 0 days.
And unfortunately, I mean, there are some schools that are doing that across, and I can let Dean Sumner, I'm sure they do it here, but it's an issue though nationally. So we want to bring awareness to that, and I really appreciate you being a physician speaking out, because that's the important thing, is talking about it. So we started a clinical trial in 2019 at Grady, because you need data to prove, right? And of course, then COVID happened, and it was such a blessing that the life care specialists were able to continue working, because patients could not have their family members. I remember we had a 26-year-old young lady that had her leg amputated, could not have her parents there. Can you imagine? And so the life care specialist sat at her bedside. But talk to us about the little bit of the preliminary data that we had.
Yeah, so I think one of the really interesting things that we uncovered that is kind of like, I don't know what I don't know, is you think about health literacy, and in my role from an IT standpoint, you send patients home with discharge instructions, and they have, a massive list of medications that they're being sent home on, a bunch of things like where they follow up, but you don't necessarily think about the fact that they've heard at this point, 10 years after I started my training, back when we first connected, patients have heard of the opioid crisis. What they have not connected, the dots they haven't connected, is the pain medication they're being sent home is an opioid. And so one of the big things that we learned very early on is that 70% of our patients didn't even know they were taking an opioid when they were taking an opioid. So they don't know the difference between, okay, well, what's an aspirin, what's an ibuprofen, what's a Tylenol, what's a Percocet, what's an oxycodone? That just wasn't at the top of mind for anybody.
And so we had a case where a man said, oh my gosh, I didn't know I was taking an opioid. I'm going home with an opioid, and my wife is in recovery. I didn't know that. So we were able to get a lock box, and so he had his medicine locked up. Had he gone home, that could have been a challenge and a big risk for his wife, but he didn't know he was taking an opioid. A lot of people know street names for pain medication, but they don't realize it's an actual opioid. So we provide a lot. What was a silver lining is how much respite we cause for nurses, because when you've got a patient pressing that pain management button, now they utilize the life care specialist. Tell us a little bit of feedback about the nursing staff at Grady and what we've received.
Yeah, it's a tremendous burden that falls on the healthcare workers, because, now we're all aware of the opioid crisis, and the only tool that we were taught along the way for how to treat pain is, here's an opioid prescription. So we at least all now are aware that putting opioids out into the world is a bad thing. But what that hasn't been substituted with is, how do you treat patients' pain appropriately? Because you don't want to just neglect has sort of been or turning it the other way and saying, oh, no, you don't need that, you'll get addicted, and then moving on to the next thing. And I think the absolute best thing, and I wouldn't even say just nurses, but all the physicians as well, is this is a huge burden that's been lifted off of our shoulders to be able to pick up the phone and call a life care specialist and say, hey, can you come help me? And the problem goes away, because they've now they've absorbed a lot of the pain management conversations themselves. And so that's, the nurses 100% of the time have said that's previously the only arsenal in their toolkit was an opioid. And now we have a whole team of people whose entire purpose is to help people manage pain.
Can you share a personal? I'm going off the list. I'm going out of order.
That's
since
fine.
you were there. Can you share a personal story of how you've utilized an LCS?
Yeah, so I'm only 30% clinical, which means I do 30% of the volume that all of my other partners in orthopedic surgery do. So that means my clinic is relatively small. And so I still see 30 patients in a half day in my clinic. They see upwards of 70, something like that, patients in their clinic every day. And everyone says, well, why can't you cut back? I'm like, I can't turn off the valve of trauma. Like, we see what comes through our door. Like, it's not like we can say no. So the answer is anybody who had trauma 2 weeks ago gets seen today, and that's just what it is. And so I'm seeing 30 patients in one day, which is, a lot of people. And I'll walk into a room, and I just can remember walking into one room that was a patient and his mom, and clearly there was a dynamic going on between the patient and the mom. Like, you don't always understand like what sort of family dynamics you're walking in on. And I knew something was wrong the minute I went in, because the son who was an adult, had previously been shot and was there for a follow-up from his gunshot injury, and his mom was the one who kept asking for pain medications. And so I was like, something's a little bit off here, but I didn't have time because I had to go see 29 other patients in the morning to be able to get into the depths of it. Now, I'm probably the person who's the most aware and the most willing to engage in conversations like that of people who do what I do, but I still just didn't have time to have that conversation. And so I backed off and I said, let me call Carter, because Carter is on my speed dial. And so I called Carter and I was like, can you please help me? And he was like, I'll send somebody over right away. And by the time I made it into the workstation, somebody had come over to help and had set up a plan for calling the patient, calling the family, had come and updated me on some of the complex social scenarios that were happening between the mom and the son. I don't even remember if they asked the mom to step out for a period of time, but like there was a lot happening in that room, and they helped me. And so we were able to work through it as a team, which is really key.
Thank you for that. And thank you, Carter. We recently got a call from a physician that we're friends with, and we're not even at his hospital. And he said, I've got a 19-year-old that was on his motorcycle, and he got hit by a truck. And he's on multiple opioids, and I don't, even as a physician, know how to taper him off these opioids. And I've called many doctors, we're working on this, can we get a life care specialist over? So we sent a life care specialist over within the hour. And the mom proceeds to tell the life care specialist, I have over 100 Oxycontin at my house. So here's the point. My son died 9 years ago, and this is still going on. That's scary. There is a fire inside of me that I cannot describe to you, because I don't want another mother to bury their child. So what did I do? I got in the car and I drove over to the hospital and I said, is it okay if I talk to the mom? The hospital is great. They were like, yep, you can go talk to the mom in the hallway. I said, let me tell you something. This could change the entire trajectory of your son's life. And I felt like I was looking at my son, Christopher, in that room, 19 years old, scared to death and in pain. But we were able to get a pain management plan in place so that we prevent addiction. And those are the stories. I can sit here and tell story after story, which I am on a time limit. I will watch Glenda Grant. But anyway, so.
Can I tell one more story?
Yes, please.
Yeah.
Okay.
So I had a woman who came from North Carolina about 3 months ago to come down and see me for her. She had an old fracture of her upper arm that didn't heal, and I don't normally see a lot of like new patient outside referrals, but she had found me and she was like, I want to see you. So we got her into clinic, and she had seen 19 orthopedic surgeons before she found me to get their opinions, and she came in on a heavy dose of opioids at baseline, and she has all the family support in the world. She has kids who live in Lyon, France, like people all over the place. So like she's got tons of support, but had zero awareness of the risk she was at from being on high dose opioids at baseline. And so she was with long conversations, and I was like, I am not operating on you until you have a plan for how you're going to get off of these opioids. And so part of it was talking to our life care specialist team. Part of it was talking to somebody who had a history and who who treats addiction medicine so they could actually give me a taper so that I could plan to get them off. I was like, you need to be off of these. I don't care who's prescribing them, but you need to be off of them in 6 weeks afterwards. And I need you to come with a written plan for how you're going to do that. And so you would think I would scare her away. And I was trying to scare her away. I was like, you really could go on to number 21, but she stuck with me, and I operated on her. And she, as far as I know, she has not called the office once. This is, I think we did her surgery about 6 weeks ago. Hasn't called the office once for a refill, no calls for pain. And she was hammer messaging my PA before surgery. So we were a little bit worried that this could have gone one of two different ways. But to get at your point about prevention, like having these conversations in advance when we have the opportunity, and we do not always have the opportunity, is so important because it has made, I texted, my PA is now in Spain on her 10-year anniversary trip, and I texted her before she left. I was like, what do you think she's doing right now? And she's like, I think she's perfect, because she hasn't messaged me one bit. So the prevention piece of it is the most important.
Absolutely. There are peer specialists that work in some hospitals, and those are people that are in recovery, and we are partnered with them, and we do work with peer specialists. For those of you that are familiar, we do have a few of our life care specialists that are in long-term recovery. The numbers are staggering of how many people they've gotten into treatment. Up at Mountain Lake, I think it's over 20 patients that the life care specialist has gotten into treatment. To me, that's saving 20 lives right there. 180 referrals to other services by one life care specialist. 180 patients. That's saving lives. That's making a difference. One story, and I'm not getting into names, and I don't want to name the LCSs, but they're all here in those purple shirts over there, and they know I'm bragging about them, and they know I love to hear stories. I get on the calls, I'm like, tell me more stories, because it's amazing. But one was working with a gentleman who had alcohol disorder, really bad. And she'd worked with him, and he was afraid that when he got home, he was going to start drinking again. Well, he was discharged and had a crisis at home, and the life care specialist was asked to go with the non-emergency EMS to his home. She did. Got him into treatment. He's into treatment 2 months now, sober. And he made the most beautiful comment to her. He said, "You're the first person that ever showed care for me." What? Like, that's one patient at a time. That's the stories that we have. And then he called her back and said, can you help my friend? Can you help my friend get into treatment? My friend really is suffering now. And so now she's helping the friend. That's what we're talking about. That connection, that human connection to care. So I want to ask you another question. John and I lived in Hong Kong for 7 years because he did that through his job, and I went along. Had no idea I was going to be going to Hong Kong. But so we went back there, and Dr. Mara came to Hong Kong, and we did this in Hong Kong, and it was really awesome. And the issues are around the world. It's not just in Georgia. It's not just in the U.S. Although we do consume, I believe, 80% of opioids worldwide, there's still issues. And so I want to ask you, you're busy, but you chose to be our chief medical officer, and you show up every time you're asked. Why do you believe in the Life Care Specialist program? Why do you spend your time voluntarily, because I could not afford to pay her? How do you do that? Why do you do that?
Yeah, I mean, I do. I drop everything for you guys, and no matter what's on the calendar. And that's a very, and I say no to probably 95% of things that I get asked to do, because I also get asked to do a lot of things because I'm a woman in a position of leadership in orthopedics, which is also extremely rare. So I say no to almost everything, but I say yes no matter what else I have on the calendar to you. And so I was thinking about this question because you actually haven't asked me this question before. And one nice thing about Grady, and the reason I like to be clinical, is because every single patient, I mean, the stories of helping people is just so satisfying. And it's the best part of my job, is the one person that I'm helping one day who is at the worst moment of their life. I spend the other 3/4 of my time on the macro scale, analyzing the problems we have as a health system. And so that's where I sort of see myself as like the data person. And so we always look at the opioid crisis as a big public health crisis, which it is, and all of the solutions coming down on us are very macro, and how do we treat, the big global problem? And I think the reason that Cammie and I hit it off, other than she's my shero too, is because the only way to solve this problem, in my opinion, is at the individual level. And you're the only person doing that. And so many people are taking this from, sure, the problem needs to be approached from both sides, but why this is so important to me and why I remain as clinically active as I am is because I love to help the one person. And that's what you're doing. And it's just adding up at this point. I mean, Cammie and I met just two of us or three of us with Bailey in my office the very first time reviewing things. And I was like, sure, this sounds great. And then looking around the room now, it's pretty amazing how far this has come in the last 8 years.
Thank you. Just so you guys know, the North Star is to have life care specialists in every hospital. Well, it's going to happen in Georgia, period. That's done. But we want to do it nationally. It's going to be national. It should be in every hospital across the country. But yes, the first goal is to get them in all hospitals in Georgia, although we're in Arkansas. And we just did our 1-year review in Arkansas. We received opioid settlement money in Arkansas. We have 2 of our life care specialists here from North Regional Hospital in Arkansas. When we did the review with their CEO, they said, the opioid education is so critical to our patients, but what's happening with our emergency room is that people are using it on a regular basis every week, every month. We're seeing the same people come through. There's a mental health crisis going on in our country, and it's the coping skills that they provide on the mental health side that has been so, so valuable and so important as well. So I just wanted to add that out and do a shout out to Arkansas because they're here as we keep talking Georgia. Okay, one more question and then we'll open up for question and answers. How is the LCS program, what do you see happening with providers and prescriptions? We know the prescription writing, it is decreasing. Is it fast enough? No. Do we still need to work on it? Are dentists also, not all dentists, but is there overprescribing with dentists? Look, how many of you have kids that are going to get their wisdom teeth taken out? You do not need 30 Percocet. You need Motrin and ice. You don't need an opioid when you're getting you just don't. And so those are the things that we advocate and teach. So we see that there is a decrease in the prescription writing, but there needs to be more. What do you see happening?
So I feel like we're at the tip of the spear to some degree, where we are aware of what's happening and we've reduced and we're willing to engage in conversations with patients when it's always much easier when they say, I hurt, here's a prescription. And rather than that, to sit down and have a conversation with them. Every now and then I'm completely astounded by patients who get referred in on massive amounts of opioids. I was like, this is so 1990s. Like, how is this happening still? And so there's still a massive provider variability in prescribing. So figuring out how to get everybody a little bit more standardized, I think is going to be a big piece of the future when it comes to the actual prescriber side. It's going to be interesting to see what happens with the Center for Medicare and Medicaid, because we're in the process, and a lot of health systems are going through that right now with like forced mandates for patient-reported outcomes for certain procedures and having to report to CMS. The future and possible emerging mandates are related to opioid prescribing. And one of the specific components, at least from what I've been reading, and none of it's been beneficial, is using alternative non-opioid strategies for pain management. And I don't know that a lot of other places that don't have LCSs have that in place. And one of the things that's been really good for us is that right as the opioid settlement funds have come out, we were sort of waiting in the wings to step in. And I look at the CMS requirements potentially for non-opioid strategies for pain management, for that being kind of maybe hopefully our next best thing, is that we'll have the opportunity to get into more places, because even though you can read all you want about behavioral-based strategies for pain management, like you need a person to help deliver that. Like an orthopedic surgeon's not going to do that. And so I don't know what CMS is going to bring, but I think that might be the next thing.
It was really interesting when my husband had his knee replaced and the surgeon prescribed 2 opioids. And I literally wanted to kiss his face. I was like, who are you, right? And I wanted to know everything about him because he only prescribed 2 opioids. But we started talking and I said, how many patients call you back for a refill because you only give 2? And he said, less than 5%. I said, wow. I said, well, what do your counterparts prescribe? 80. Do you see the difference? And what he said was when patients know, like if you're in pain and you only have 2 pain pills, your brain tells you, I think I'm going to hold off. I'm going to wait. I'm going to get through this wave. I'm not going to take it. He said sometimes they only take 1. Or they don't even take either one of them because their brain is like, I'm going to wait in case it gets really bad. Then I'll take it. And there's a lot of bad side effects to opioids. So that's and I think you missed my story, but I was talking about you. Yeah. Yeah. Poor guy married to me. I was like, we're not getting any opioids. Nope, sorry. Here's some Tylenol. Here's some Motrin. You'll be okay. Okay. So let's open it up for Q&A because I could just sit up here and tell story after story. And okay, Holly Lind. And Glenda's got a mic for you.
Cammie knows who I am, but for the rest of you who don't know, I'm Holly Lindy. I'm the Executive Director of the Opioid Crisis Abatement Trust, and we're super pleased to be funding some of the life care specialists, particularly Grady. Yay! But I was curious. Unfortunately, there have been a lot of broken bones in my house. Thankfully, not mine, knock wood, over the last few years. And my mother's had knee replacements. Gave my daughter 1 opioid one time and she hallucinated, but it's fine. But I'm hearing a lot of talk about hospitals, and a lot of the surgeries that my husband and my children have had for broken bones have been in outpatient clinics. So I'm curious what the plan is for putting life care specialists or something in more of an outpatient setting, ambulatory surgery center.
So hot off the press, we had funded one of the studies that we had funded, and I don't even know if you know this yet. I've just seen the very early NFL data. So we were funded by the National Football League for a study looking at outpatient surgery. And one of the challenges with that is you don't have either the space to do face-to-face encounters, or you just how quickly things evolve when you're having outpatient surgery. There may not necessarily be the time to have the level of engagement. And so we proposed doing a 3-arm. So a control that just received the standard, here you go, here's your prescription, and here's how to take it, doing a face-to-face and doing virtual. And the early data says that actually virtual might be the best with a life care specialist. And the interesting thing about that is I asked Carter, I said, why do you think that's the case? And we haven't done the final data analysis, so don't hold me to it. But Carter was like, it's, we're comfortable because we're not being shoved between room to room because there's not always dedicated space for us. He's like, but most importantly, the patients are really comfortable because they're in their home environment. Like they open up a lot more. And so I think there's a huge opportunity to engage with patients who are doing outpatient surgery via telehealth or virtual.
I think it helps patients too when you're right before your surgery to have the life care specialist talk to you to set the expectation of pain and show you a roadmap. Look, you're going to be in pain and you're going to look like this day 1, day 2, then it's going to taper here, and then following up with that patient. How is your pain level? How are you doing? And having, again, that coach there, it helps the patient feel like they're supported. But that was a great question, and I'm so glad you're here, Holly.
Thank you. A question about, you mentioned rural communities being especially impacted by the opioid crisis, and what are the resources available for rural hospitals that do want to bring a life care specialist but may not have the financial resources to bring that person along?
I love that question, Claire. Thank you. I didn't tell her to ask that either, but I love it, Claire. Thank you. So what we're doing, we have submitted right now, there are 7 grants they've already been submitted. 6 of them, CWC is not the primary. There are other hospitals asking for this program. We're the vendor that supplies the life care specialist. And so there is, remember I was talking about that $1 billion that came into the state, thanks to Attorney Chris Carr and a lot of other people working very hard. We've been able to get opioid abatement funding to fund the life care specialist role. We've received money at Grady, Arkansas, many rural hospitals, and we have a lot of requests in right now. If you are at a rural hospital, you can work with CWC. We've got the grant already written up, the data, everything. We handhold you through the entire process, and we're partnered, and we look for partnership This is not just a 2-year or 3-year. We are wanting long-term partners. And the ultimate goal is to get a reimbursement code, because this should be paid for, period. End of story. But this is getting us a start. This opioid settlement money. My son died for this, and so I believe that it's very deserved and earned, and we work very hard for this money, and it's workforce development. Look what it's doing in rural communities. It's putting people to work as well in the community. So it's just win-win-win all the way around. But that was a great question.
Good morning again. Thank you both as well for your candor. I wanted to talk specifically regarding the providers. Obviously, we know there's various levels of providers, mid-level providers, anything from a medical student, physician assistant, NP. What in medical innovation did you see in the curriculum specifically that may help alleviate some of these issues? I know in the past, providers have been taught to, provide the medications and maybe lack of treatment, or just handle the surgery, or I'm just trying to be whatever specialty and I'll let somebody else deal with it. What do you see for the future of curriculum that can help alleviate some of these issues we're speaking of?
Yeah, I mean, I think some of it is definitely didactic. That's a great question. Didactic education, like it's something that needs to be introduced like from the minute you walk through medical school doors. Like step one is awareness of the current environment and some of the challenges that we face as providers. And that, a lot of times you see, because I would say that your access to patients in pain in general is greater than your access to resources to help patients treat their pain. And so the first step 100% for me is awareness. And so they say that you only remember 5% of things that you're taught in a lecture. And so sure, you need to introduce it in that setting, but then living that. And so stage one is awareness. Stage two is probably confusion, because at this point you're like, well, shoot, like I know that, I know the patient's in pain. I know I'm not supposed to provide them with opioids, but now what? And then stage three is really like, okay, now I have a resource. Now I have somebody who can help me. And so I think, majority of medical training is done like on the fly. And that's even the same with a lot of our advanced practice providers. So PAs, nurse practitioners, they all do time on clinical settings. And I think the further we get away from here's a pill, you have pain, here's a pill, and have other approaches to pain management, I think that's where it's actually going to stick. But I think you have to start that awareness piece of it from the minute that people come into medical school.
And I also wanted, while you're getting the mic to her, I just want to say that, when you're coming in with a new position in hospital, these life care specialists are pioneers. Nobody knows who they are. And some nurses, what are you doing with my patient? Who are you? And why are you here? And what's going on here? And so we come in and I bring food, okay? And I do a lot of food, and I do a nursing orientation, and we explain that we're here to help, because nurses are really overworked, and angels on earth, by the way. I don't know what I've done without the nurses when Christopher was in the hospital, but point being, you have to have champions in the hospital. Yes, you've got to have the C-level absolutely buying in, but it takes the chief nursing officer, the hospital administrator, you ladies over here. You've got to have champions, but you get one good story. You help one nurse, you help one physician, then it spreads like wildfire, because it is a new position. They don't know what you do. They don't know the value you bring. So it is pioneering, and it's not easy. And I love you guys. I'm just saying. Okay. Any more? I think there was somebody else had a question.
Yeah.
Yes, Cammie.
This is really a comment more than a question, and first, thank you, Cammie and Rural Health and Mercer, for putting on this conversation today. It's so important and great to be part of it. Just a comment about Grady, and I don't know if this was a doctor practice or a hospital practice that was brilliant, but a friend of mine, Dr. Sadilak, replaced her hips and one knee, and she did spend the night both times, or 3 times, but they sent her home with very little pain medication, but also with a Narcan kit. And I thought that was brilliant, because the education that went along with explaining the medication and how dangerous it can be, I thought was wonderful. So I just wanted to let you know.
Thank you for sharing that,
great
Kelly.
that
and you
was.
all have naloxone in your kit. Dean Sumner made sure of everybody is leaving here with naloxone. Everyone should know naloxone. Everyone. You don't know. And if you think, well, my kid's not going to need it, well, maybe it's your kid's friend. Maybe you're at a gas station. Maybe you're at a coffee shop, because that's how it's happening. So, yeah, don't get me started on the naloxone. I'll keep going that. I'm going to do that after the documentary. But, yeah, it's so critically important. And all the life care specialists, when they're doing that opioid education at bedside, they're also teaching about naloxone. Would love to be able to hand it out more. So thank you for sharing that, Kelly.
Yeah, and it's good feedback for us that the IT system's working.
Any other question?
Hi, I'm Ashley Black. I'm the director of Rise Up, our Addiction Recovery Support Center in Dublin. I'm also a person in long-term recovery, and as someone that has had to have surgery in recovery and have that fear of the pain meds, I actually did it without meds. But what do y'all see as best care practice? And then the other thing is, if our hospital doesn't participate in your program, are nonprofits able to reach out to CWC to maybe have a life care coach work with some of our peers if they're experiencing a surgery?
Yes. We're all about partnering, and bless you, because that was the issue when I'd have to go back to the emergency room with Christopher. You know, have you ever seen that show where Shirley MacLaine is screaming, "Give my daughter the shot, it's 11 o'clock"? That was me, only I was saying, don't give him. Okay. And it's getting better, but emergency rooms don't always know what to do with people in recovery and how to handle the pain. So it is an issue, and I don't have an easy answer for it, because you don't want to have to take the opioid, but it depends on what happens of why. But you do need that support system if you do have to take that medicine. And so, yes, the answer is we would love to partner. Yes.
And what I would add to that is a lot of times we don't know. So I think families and patients who, my practice is trauma, so I definitely don't always know when patients have or underlying or baseline is that they're in recovery. So we have to ask the right questions from the beginning. I think, trauma is a very narrow subset of all the surgeries that are done. And one of the, I'm playing catch up a little bit with the new CMS mandate for total hip, total knee. And one of the questions that is reportable is, are you on a baseline opioid? So that question is going to now be hard stopped in our electronic health record. So we will know, and sure, you have the PDMP, but like if someone gets prescriptions in Alabama, we don't necessarily know. But that question now needs to be asked before you can even get entry into the OR. So I think there's steps forward to at least knowing, are you in recovery or have you taken an opioid in the past? But then the question is, what do you do? And I'm lucky I have a buddy, and she's on my speed dial. So if I have somebody who comes in, like that woman I was talking about, who says they're in recovery, they want to have a different strategy for pain management. You've got things like buprenorphine, and I don't prescribe that, but I have somebody who does. And I'm like, hey, can you please go see Dr. Stack? She's emergency medicine, addiction, and toxicology trained. And so she's, her, she's amazing. So she's my speed dial when it comes to somebody with complex needs when it comes to pain management. So I always call her. Not everybody has an Elena Stack, but hopefully in the future they will.
The other issue, too, to be aware of is the elderly are really beginning to get, they've for years overprescribed. They go in, they're hurting places, right? I hurt here, my knee hurts, my this hurt, and they just throw a lot of prescriptions to them. Mm-hmm. And then what we're seeing is a lot of overdose with elderly because they don't remember how if they took their pill and then they take it again. And so we are seeing issues with elderly in a lot of population areas across the state. Yes.
Hi, my name is Nola Daughtry. I have with a nonprofit organization called Drug Free Grady in Cairo, Georgia, and was wondering about the grants, if they were restricted to just hospitals.
No, ma'am. No, you actually, Holly's the one you want to talk. Holly, you want to answer that question? But no, absolutely, they're not actually treatment centers, recovery centers, nonprofits. You just have to apply. They have everything online, which will give you a microphone, Holly, and we can put up a GAopioidtrust.org. There's a process, and they have an amazing team, and they're a very small team working very, very, very hard. So you want to say something? Go ahead.
Yeah, our website is gaopioidtrust.org, and you heard it here first. We will have a new website on Monday because right now the current one is awful. But there's It was done before I arrived. I do have an amazing team. Unfortunately, my team is deep in the trenches of making sure that grades for all the applications are in this year, so that's why they could not join me today. GA Opioid Trust, the best place to look is the Notice of Funding Opportunity for the last 2 years, 24 and 25. Those give a huge amount of information about everything that you can apply. Pretty much any organization can apply. Nonprofit, university, for-profits can apply. We do research, harm reduction, prevention, treatment, recovery. There is, at the back of the NOFO, the Notice of Funding Opportunity, there is a list of the types of projects that you can apply for. Ashley is actually one of our grantees as well. If it's me and Taylor, that's it. Although we are hiring a new person. I did get permission to finally hire a new person. So I'm very excited that our team is growing. But if you email GA Opioid Trust at dbhdd.ga.gov, but if you go there, you can contact us. We'll answer your email. Please.
Thank you. They do town halls too all over, and they do a slide presentation, and they do a really good job of helping everybody know what to do. All right, we're almost wrapping up. Any more questions? Final questions? Yes.
Hey, good morning. I have one last question. It's related to your life care specialist role. For any of your life care specialists that may be serving in a health system that has a pain management outpatient setting clinic, if they are to visit a patient in the inpatient setting and they say, oh, I'm already seeing pain management for, those services, what does that conversation look like moving forward for your life care specialist to that patient?
So the question is, if they have the same patient that they've seen inpatient and now they're seeing him outpatient?
If that patient is already being monitored by a pain management clinic within that health system, what would that conversation look like?
Oh, okay. Well, we definitely want to partner for sure. We partner with the social workers. We partner with the pain management clinics, like at Grady, Tante works. And it's just communication. We just have to communicate and share. And the big thing is to stay connected if the patient requests it. That's a big one. When you get out of the hospital, back in the day, the doctor used to call you on the phone and say, hey, how are you feeling? It's too big now. It's hard to do that. But the life care specialist stays connected to patients once they're discharged if the patient wants or requires it. And that's been huge, especially for people that have gotten into treatment. Like one life care specialist just heard from a mom, and she's saying, I just want to thank you because my son's a year sober. Isn't that correct, Mandy? Yeah. A year later, she hears from the mom. Those are stories that matter.
Yeah, and I think the pain management specialists in general are extremely receptive because this does not cross their swim lane at all. Like they are largely proceduralists who want to do, blocks and like treatments. A lot of our pain management specialists don't even prescribe opioids, and they definitely don't have behavioral-based strategies for pain management in their armamentarium. So, for us, like if there ever seems like there's any sort of perceived conflict or overlapping swim lanes or something like that, like they reach out to us and say, hey, can you help have this conversation? Then you call and you're like, hey, they're not trying to like step on your toes. They're just trying to, oh, okay, great, bring them on in. But it sometimes takes a conversation with somebody in the middle to arbitrate.
So now we're going to wrap up. Now, this part, I got to tell you, this is a big day. Dean Sumner surprised me and had her team, Amanda specifically, design a healthcare pen for the life care specialists. I have pin number 1. It has a 1 on the back. And it's hard not to get emotional on this. This is my son's face on this pen. And it says Mercer School of Medicine, and it says... So I'm going to get through this, but this is incredibly symbolic for this to be happening today, that these life care specialists that you see over here, they have worked so hard. They've gone through the online curriculum. They've gone through the practicum at Grady Memorial, and they're out in the trenches, and they're being pinned today by Dean Sumner. And I'm going to read the names off. The first life care specialist to be pinned today is Alyssa Womack from Stevens County Hospital. Brandy Merritt, Coffee Regional Medical Center. Brittany Massey, Grady Memorial Hospital.
Oh, sorry. Slow down. She told me to read really fast. Glenda told me to read fast. I was just doing what I was doing. Sorry. Let's start over now. Brittany Massey, Grady Memorial Hospital. Chaz Lovely, Grady Memorial Hospital. Dante Hollis, Grady Memorial Hospital. Erica Jones, North Arkansas Regional Medical Center. Mandy Kuntz, Mountain Lakes Medical Center. Michelle Mitchell, North Arkansas Regional Medical Center. Rachel Jones, South Georgia Medical Center. I didn't even think that I could have looked over to the right. Okay, I'm just nervous. This is so amazing. Ah. Dreams do come true. I'm going to give you all a little break. So we're going to do a massive photo op with our team over here on the right with Dean Sumner. Again, I want to thank the supervisors of the Life Care Specialist Program, all of you for being here. You know who you are, Grady, Coffee, everybody that's here that supported this team to make this day happen. Thank you so much. Take a quick, 10-minute break? Oh, sorry, hold on 1 second.
I'm going to take a point of privilege now because I think it's such an important event. We work so hard to bring care to underserved populations in our state. And one of the most important things we can do is train young physicians to understand the complexities of rural health. Vicki Lewis is here. Vicki, stand up. Yesterday, Coffee Regional got fully accredited for their internal medicine residency in Douglas, Georgia. You have no idea how much work goes to that. So, I know in Mercer's case, and we only accept Georgians, but if a Georgia student gets a Georgia residency, there's over a 90% chance they stay in Georgia and near where they trained in residency. So it's about transforming this state for the better. So congratulations. I know Vicki's got to slip out, and I wasn't going to let her get away, so I apologize.
And now you can go on break and definitely go check out the Georgia Recovery Bus and sign the bus if you'd like on your break.